Welcome to Dr. Health Hub, where every episode begins with a doctor tip you can trust. Today we're talking about breast cancer. Before we go any further, let me tell you what we're going to talk about today. We're going to talk about what breast cancer really is, how common it is, what causes it, and what signs people should actually pay attention to. We'll talk about screening, when to start, how often to do it, and how family history can change that plan. We'll also talk about questions many people quietly worry about, especially if breast cancer runs in their family. What it means if your mother or sister had breast cancer, whether genetic testing is always needed, and whether there are real ways to lower risk, including lifestyle changes and, in some cases, preventive medication.
That's exactly the right way to approach this. Breast cancer occurs when cells in the breast begin to grow in an uncontrolled way. Sometimes these cells form a lump. Sometimes they're found on imaging before a lump can be felt. Breast cancer can affect women and, less commonly, men. Most cases occur in people with no strong family history. One important message to remember is this: breast cancer is often very treatable, especially when it is found early.
People often ask a very direct question: what causes breast cancer? Is there one main reason it happens?
There is no single cause. Breast cancer develops through a combination of factors rather than one specific trigger. Some factors cannot be changed, such as age, biological sex, genetic mutations like BRCA1 or BRCA2, and family history. Other factors relate to lifetime hormone exposure and lifestyle, including early onset of menstruation, late menopause, obesity after menopause, alcohol use, and physical inactivity. It's also important to say this clearly. Many people who develop breast cancer have no obvious risk factors at all.
That brings up an important concern we hear very often. Many viewers ask, if my mother, sister, or daughter had breast cancer, what does that mean for me? When should first-degree relatives start screening? And is there anything they can do to lower their risk?
That's a very common and understandable question. A first-degree relative means a mother, sister, or daughter. Having a first-degree relative with breast cancer does increase risk, but it does not mean cancer is inevitable. Most people with a family history will never develop breast cancer. Our goal as doctors is to identify who needs earlier or closer screening and who does not.
So how do medical guidelines guide screening when there is a family history?
Screening for people with a first-degree relative is individualized. There is no single age that applies to everyone. A commonly used medical approach is to begin screening about 10 years earlier than the age at which the youngest affected close relative was diagnosed. However, routine imaging is generally not started very early. For many people, screening begins around the early 30s or later, depending on overall risk. For example, if a mother was diagnosed at age 45, screening for her daughter may begin around age 35. Breast density, other risk factors, and personal medical history all matter.
People also hear about genetic testing and wonder if they should be tested.
Genetic testing is not recommended for everyone with a family history. It is usually considered when breast cancer occurred at a young age, when there are multiple affected relatives, when male breast cancer is present, or when ovarian cancer runs in the family. In these situations, referral to genetic counseling is recommended before testing. Genetic counseling helps people understand what testing can and cannot tell them, and how results may affect care.
If someone is considered higher risk, does screening look different?
Yes. For people with significantly increased risk, such as confirmed genetic mutations or very strong family history, screening may start earlier and may include breast MRI in addition to mammography. MRI is more sensitive, especially in younger people with dense breast tissue. It's used carefully to improve detection while avoiding unnecessary anxiety from false alarms.
I read an article that said there are medicines that can lower breast cancer risk. Is that real?
Yes, it is real, but it applies only to a carefully selected group of women. These are called breast cancer risk-reducing medications. They are not for everyone with a family history. Doctors consider them only when a woman has a clearly increased risk confirmed using formal risk assessment tools. Family history alone is not enough.
So having a mother or sister with breast cancer does not automatically mean someone needs medication.
Correct. Family history is an important signal, but it's only one part of the picture. We also look at age, reproductive history, breast density, previous biopsies, and overall risk estimates. Only women with moderate to high risk may benefit from preventative medication.
What types of medicines are used when prevention is considered?
There are three main groups. Tamoxifen can be used in both premenopausal and postmenopausal women. Raloxifene is used only in postmenopausal women. Aromatase inhibitors are used in selected postmenopausal women at higher risk. These medicines reduce the risk of hormone-positive breast cancer. They do not prevent all types of breast cancer.
When would doctors usually start these medicines?
Only after careful assessment and discussion. They are usually considered in women aged 35 or older after screening is up to date, and only if there are no medical reasons that make the medicine unsafe. This is always a shared decision.
How long are these medicines taken?
The standard course is 5 years. Large studies show that 5 years provides meaningful risk reduction, and the benefit continues even after the medication is stopped. Longer use is not routinely recommended for prevention.
What should patients be monitored for while taking these medicines?
Monitoring is essential. With tamoxifen or relaxifene, doctors watch for blood clots, leg swelling, chest symptoms, and abnormal vaginal bleeding. With aromatase inhibitors, we monitor bone density, joint symptoms, and overall bone health. That's why these medicines are never taken without medical supervision.
So this is an option, but not a requirement.
Exactly. Preventative medication is optional, not mandatory. Many women choose enhanced screening and lifestyle measures instead, which is completely appropriate. The most important thing is informed decision-making, not fear.
Let's talk about symptoms now. What should people watch for?
Breast cancer does not always cause pain, especially in early stages. Signs to watch for include new lumps or thickening in the breast or underarm, changes in breast size or shape, skin changes such as dimpling or redness, nipple inversion or unusual discharge, or changes that do not go away. Many breast changes are not cancer, but any new or persistent change should be checked.
When people without strong family history start screening,
for women at average risk, most guidelines recommend starting regular mammography between ages 40 and 50, with screening every 1 to 2 years depending on age, risk, and shared decision-making. Screening saves lives by detecting cancer before symptoms appear, when treatment is often simpler and more effective.
if something abnormal is found, what usually happens next?
An abnormal screening result does not automatically mean cancer. Further evaluation may include additional imaging and sometimes a biopsy. A biopsy is the only way to confirm a diagnosis and guide treatment decisions.
Many people worry that diagnosis automatically means aggressive treatment.
Treatment today is personalized. Some cancers need only limited treatment. Others need a combination of therapies. Advances in care have greatly improved survival and quality of life. Before we close, let's bring everything together. Today we talked about breast cancer not as something mysterious or terrifying, but as a condition we can understand, monitor, and often treat successfully. We talked about what breast cancer is, why it happens, and why family history increases awareness but does not mean cancer is inevitable. We talked about screening, genetic counseling, and what happens if something abnormal is found. We also talked about prevention, including lifestyle choices and the fact that preventative medication exists for a small, carefully selected group, and that it is always a choice, never an obligation. The most important message to remember is this: knowledge reduces fear, early attention improves outcomes, and personalized care matters more than assumptions.
Thank you for that doctor tip you can trust. And thank you for watching Dr. Health Hub. Don't forget to like, share, and subscribe for more trusted health education. And remember, your health is your wealth. Stay tuned for the next doctor tip you can trust.